So what I have for you today is schedule check. Today and then Thursday, our last two lectures in cardiovascular, and we're done for the semester. We got a pre and a post quiz this week, like typical, and then we have our final next Tuesday. Same drill. Online format. It's more like an exam 3. It'll be cumulative, maybe 20% up to 25% cumulative stuff. But a vast majority, 75 to 80% will be all the new content since the last exam. Pretty straightforward. I'll have office hours, one last office hour on Monday before the exam on Tuesday in case anybody has any last minute questions. I have 3 questions for you. You ready? You missed the jokes, huh? Yeah, you're like, not so much, but if you want me to say yes, yes. What do you call a person who doesn't toot in public? A person who doesn't toot in public. A private tutor. Come on, that one's good. Why does DNA have no fashion sense? Why does DNA have no fashion sense? It always wears the same old jeans. They haven't gotten any better, have they? No. End of the semester, they're still corny as ever. What stays in a corner but travels around the world? Stays in a corner but travels around the world. A stamp. Nicely done. You didn't get the fart joke, but you got that one, huh? All right. So, for cardiovascular diseases, what I want you to do first up is take out a scratch piece of paper on your tablet or iPad. I would like you to draw a simplified picture of a heart. Just a simplified diagram. And it needs at least 4 things. It needs a right ventricle, it needs a left ventricle, it needs a right atrium, and it needs a left atrium. You're not turning this in. It's a physiology class. It's not a Art 401 class. Okay. All right, just a show of hands. I want to know who the dreamers are. How many of you drew a heart that looks like this? Come on, be honest. Come on. Who drew a heart? Nobody? Oh, I'm so sad. Okay. Nobody. That was a pretty good heart, actually. So my sort of simplistic mind just likes to draw it like this. How many of you drew it like that? Or something similar? Kind of. Okay. All right. So what's this? The right atrium. And this? The left atrium. And this? The right ventricle. And this? The left ventricle. Nicely done. So from 202, where does blood enter the heart? Right atrium, correct? Blood's going to come in, and this is what we call venous return. Correct? It flows from the vena cava into the right atrium, then where? To the right ventricle. And then from the right ventricle, where does it go? It goes to the left ventricle? We have a septal defect. We'll get there. We'll get there on Thursday. Where does it go from here? To the lungs. Okay? Where does it come back from the lungs and enter? The left atrium, right? Correct? This is from the lungs. And then where does it go? To the left ventricle. And then from the left ventricle, where does it go? It goes out to the body via the aorta. Okay, so that's the blood flow path in the heart. You remember that? That took like an entire lecture in 202. You remember that? And there's valves, and we'll talk about the, tricuspid and the mitral, bicuspid valve, tricuspid, bicuspid, the aortic valve. We'll talk about the valves on Thursday, but it's kind of important for you just to kind of remember blood flow. Let me just see if sometimes on the video, I have to zoom in on the board. Yeah, I'm going to zoom in for a quick second. Just so you guys can see that. And then we'll zoom back out. So next up, and we'll just keep this on the board to reference, okay? But which side of the heart is considered the working side of the heart? Right or left? The left side is considered the working side of the heart. Okay, so we're going to talk about heart failure. We're going to talk about vascular disease, arterial sclerosis. We'll talk about valvular disease. We'll talk about some of the treatments today and Thursday. But in general, the right side of the heart is basically just like a bucket. It's to recapture the blood from the extremities, push it to the lungs, have it become oxygenated, bring it back to the left side of the heart, which is the working pump of the heart, to eject it out into the periphery, to the body. That's simplistically how it works. It's just a pump. Kind of a 4-chambered pump. Really, there's 2 pumps. There's a right pump and a left pump. Now, during development, it starts as a blood vessel, as a tube. And then it folds into a U, and then it almost like fuses together, and then it pinches off into 4 chambers. Can you visualize that? That's embryologically how the heart develops. And then the left side becomes a lot more musculature because it's the working side, higher pressures than the right side. And that's important for us to understand because we're going to talk about hypertension, which is a problem in the aorta, which is part of the answer. What's the difference between preload and afterload? So who can answer that question for me? Who can define preload and who can define afterload? And tell me what the differences are. Preload is, in fact, the load on the heart before it contracts, which is synonymous with the blood that's coming back from the extremities as venous return. So if you increase venous return, you increase preload. You fill the heart more with volume on preload. So on the next heartbeat, more blood moves from the right side of the heart into the left side of the heart. Obviously through the lungs, but that reservoir on the right side is bigger, so it makes more volume on the left side. Okay, what's afterload? Okay. It's not the amount that goes into the left ventricle, it's actually the load on the aorta from the left ventricle, or what's leaving. Afterload. So the afterload is after the heart beats, it's the load on the heart that is the back pressure from the aorta. or aortic pressure, which is also synonymous with arterial pressure, mean arterial pressure. So the afterload on the heart is the load the heart has to push against in order for blood to come from here out into the aorta. So if a patient's hypertensive, they have high blood pressure, is the afterload higher or lower? Does that make sense what I'm asking? A patient's hypertensive, they have high blood pressure, high mean arterial pressure. Does that make the pressure the heart has to work against higher or lower? It makes it higher. So the afterload goes up. The heart has to work against a bigger pressure head, so the heart fatigues more quickly. Does that make sense? Okay. So just some kind of fundamental concepts from 202. I kind of like doing it this way versus kind of, we always do like the normal physiology in the background from 201 and 202, and then we kind of get into the diseases. So this is the diagram that you're more familiar with. I think this is helpful just to be able to show it simplistically with arrows on how it flows. Okay? But on the left side of the heart, we've got our bicuspid valve, also known as the mitral valve between the left atrium and the left ventricle. It's not really shown here, but we've got the aortic valve, which is right at the left ventricle to the aorta. This is probably one of the most common valves that's replaced. And then we've got the tricuspid valve, which is on the right side of the heart, lower pressure, so it doesn't fail as often as the bicuspid or the aortic valve because it's lower pressure. But tricuspid valves do fail later in life. And of course, there's congenital abnormalities in lots of patients, and so those data are unique. But the tricuspid valve separates the right atrium from the right ventricle. Now, the types of heart disease that we're going to kind of cover: congestive heart disease, arterial sclerosis, ischemic heart disease, valvular disease, pericardial disease, as well as some congenital diseases. And we'll talk about some of the treatments that we use. But first up, let's talk about congestive heart failure. Okay, CHF, congestive heart failure. Another term for it is chronic heart failure, also abbreviated CHF. Okay, so chronic heart failure usually happens over a longer period of time. And the reason it has another name like congestive heart failure is it's oftentimes associated with the left side of the heart, CHF. So if the left side of the heart is failing, the pump is wearing out. Okay, trying to think of an example. How many of you have a pool? Grew up with a pool? Know about the pool pump that moves the water through a filter? Okay, they don't last forever. They last like 5-6 years maybe, and then you have to replace them. As they get old, what does a pump start sounding like? It gets really noisy. I don't know if you've ever heard a pump failing, but it's like if it runs like normally, it's like right. It gets really loud and rattly because it's working harder to move the water. Here, when this pump starts to fail, it gets noisy. You can hear it under a stethoscope. You can tell. You can also evaluate performance using sound waves or echocardiograms. The backup of fluid goes, if it doesn't leave the aorta, where does it back up? Where does the fluid back up into? Into the lungs, right? So that's where the congestion happens. That's why patients have trouble breathing with CHF, because there's a lot of excessive fluid in the lungs. There's also excessive fluid that sits around the pericardium, in the pericardial sac, puts pressure on the heart because you're just not moving fluid as well, so it's pooling in places it's not supposed to pool. So usually it's a systolic problem. It's not ejecting on systole. Systole is the contractile phase of heart function. Diastole is what? the rest or the relaxation phase, okay? So this is usually a systolic problem. It's a forward failure. The pump isn't moving blood out of the heart. So you have a decrease in cardiac output, right? Now I'll put a formula up here. We're not gonna do a lot of formulas, but cardiac output is calculated as heart rate times what? Stroke volume. So if the heart rate stays the same, but the volume on each contraction or each stroke of the heart, the volume goes down, heart rate stays the same, what happens to cardiac output? It goes down. So how does the heart compensate if stroke volume lowers? Heart rate goes up. Cardiac output stays the same. Well, you can only raise your heart rate so much, right? And then you wear it out. Do you see what's the problem? That's the problem. So the etiology is some sort of abnormal load. Chronic hypertension. Abnormal load on the heart can cause heart failure over decades. That's why high blood pressure is not a good thing. Okay? High blood pressure when you're getting ready to run a race. High blood pressure when you're getting ready to take my exam on Tuesday. That's normal physiology. Chronic hypertension all the time for 20, 30, 40 years, and now you're in your 60s, 70s. Do you see what the problem is here? That's an abnormal load. The pump has to work harder. You can compensate by raising heart rate only so much, and then you fatigue the organ. Endocarditis. So that's a chronic inflammatory reaction that's happening on the inside lining of the heart. Okay? Chronic inflammation. So congestive heart failure, how does the heart compensate? Okay, well, we talked about this formula, cardiac output, CO equals HR, heart rate, times stroke volume, or SV. So let's look at 3 different mechanistic pathways that can manage some of these processes. So number 1, the first thing that can happen is you're going to release, when your heart starts to fail, or the output is low, cardiac output is low, you're going to detect that and say, I'm not getting enough blood flow to the brain and to the distal extremities. So I'm going to increase norepinephrine. Norepinephrine is a temporary short-term response. And what does norepinephrine and epinephrine do? Stimulate sympathetic or parasympathetic activity? Sympathetic. Sympathetic activity does what to heart rate? It goes up, right? So in this formula, you've compensated by raising heart rate to increase contractility. Now that works pretty well, like we talked about, for only a short period of time. And eventually what happens is you start impacting vascular resistance, right, in the blood vessel. And over time, it increases what we refer to as total peripheral resistance, or TPR. And increasing total peripheral resistance ends up lowering the amount of blood that returns to the heart, or venous return. So then on the next subsequent heartbeat, you have less blood ejecting. So it's a short-term fix. Norepinephrine, or stimulating the sympathetic nervous system. Number 2, the renin-angiotensin-aldosterone pathway. So within this system, if you recall, angiotensin converting enzyme, or ACE, increases thirst by converting angiotensin 1 to angiotensin 2. And this helps to conserve water at the kidneys, and it ultimately increases blood pressure. Well, why? Why is this a good thing? Well, if you increase blood pressure, then you increase venous return, because there's more pressure in the periphery, more blood flows back to the right atrium, and eventually you'll get a greater output on the next few cardiac cycles because you've been conserving water, maybe drinking more water. But also very temporary, right? Because eventually you'll increase your mean arterial pressure to a point where you cause a bigger afterload back on the left ventricle, and now you've just exacerbated the problem. So step 1 and 2, temporary fixes, they may help a patient out for months to years, but then the deterioration on chronic heart failure or congestive heart failure continues. So then we're into the third category of ANP, or atrial natriuretic peptide. Atrial natriuretic peptide. So ANP is really the only longer-term fix that the body can do. This one may last a couple of years to a few years. May give a patient as many as 10 more years with a failing heart. Okay, ANP. Additional exogenous medical management. But let me explain what ANP does. Atrial natriuretic peptide is released out of the atrium, and it has a natural ability to cause diuresis as well as natriuresis. And diuresis is the increase of what? Urine production. Natriuresis is the excretion of additional sodium. So if you excrete more sodium, water follows sodium via osmosis, and then more water will follow, so you'll pee more regularly, more frequently. If you increase your urine production, you drop your blood volume. If you drop your blood volume, you overall lower blood pressure systemically. If you lower blood pressure systemically, what happens to afterload to the left ventricle? Goes up or down? It goes down. So now the heart has less work that it has to do. Does that make sense? This is the mechanism that we tap into with congestive or chronic heart failure patients by giving them diuretics clinically. We prescribe diuretics early on for patients to kind of assist with this natural process of ANP. It works really well. Patients say, oh, I can breathe better, because congestive heart failure, it feels like someone trying to breathe with someone sitting on your chest. So you could do this, you could lab partner up, say, hey, come sit on my chest, okay? And then try to breathe normally. It's really difficult. Really, really difficult. And so the first thing that they notice is a lot of that congestion in the lungs frees up, and the heart doesn't have to work as hard. So it's like someone just got off of your chest and you can breathe without this restriction. The number one complaint of patients that are being treated with a diuretic, they can sleep better, they can fall asleep easier, get better sleep. You probably give them another decade of life, or a decade until they have to have a transplant. What's the number one complaint? What do you think? I mean, come on. We complain about everything, right? Having to go to the bathroom. It's like, now I have to wake up 5-6 times a night to go to the bathroom, but I can breathe. That's their number one complaint. So those of you that are moving into nursing, being physicians, PAs, you'll become very familiar with the treatment of congestive or chronic heart failure. So this process that I keep talking about, there's a name of it. It's called the Frank-Starling law of the heart. If you recall, you probably learned about it in 202. So the Frank-Starling law of the heart indicates that the greater volume of blood that enters the heart during diastole, then the greater volume of blood that's ejected on the next systolic contraction. So the Frank-Starling law of the heart is saying, if you bring more in, on the next heartbeat, you'll get more volume of blood out. Kind of makes sense, right? The bucket of fluid that you're capturing, if you fill that to a greater extent during relaxation, and you get it over to the left side of the heart, when the heart contracts, you get a bigger bolus of blood flow out of the heart. That's the Frank-Starling law of the heart, simply put, which is what we've been kind of talking about here. So that's I like to explain it and how it works mechanistically, and then throw the name to you, and then you're like, oh, okay, well, that makes sense. Sometimes I feel like when you say, we're going to talk about the Frank-Starling law of the heart, you're like, the what? These are just two people's names. And they just were cardiovascular physiologists that were studying everything that we just talked about. All of these formulas, all of this blood flow, this is all stuff from 202. So it's 202 stuff of normal physiology baked into it, kind of some of the diseases that we're talking about in this particular class. So the heart, during heart failure, tries to compensate, and then it decompensates. And every time it does that, like these first two, is a compensation, then a decompensation, a compensation, then a decompensation, making the chronic heart failure more aggressive every single time, right? And it progresses to heart failure into a point. Heart failure is defined clinically as an ejection fraction that's less than 40%. So ejection fraction is just a percentage of the amount of volume put into the heart, right? How much of that volume is ejected in one heartbeat. And there's no pump on the planet that is 100% efficient. Neither are ours. In this room, young, healthy, athletic individuals, at best, upper 80% efficiency of your heart. That means after it's done beating, there's a little residual volume that's left over in the heart. It didn't completely eject everything. There's a little bit left over. Okay? And you remember the heart is a pump that pumps like wringing out a towel, right? So it's like a wringing motion of like a wet washcloth. And if you think about it, you can take a wet washcloth, even if you have the most like dialed in, big old hands and dialed squeeze, right? You could go back to that wringed out washcloth a couple more times and get a little bit more fluid out, right? So that's kind of the analogy that I like to use for how the heart pumps. It's a wringing motion. It doesn't pump like this. It pumps more like a wringing motion as it moves, here, then pumps here, then pumps here, then pumps here, because it's got to move it through the tube. Like squeezing a tube of toothpaste, you kind of squeeze from the back end as you're kind of working it, right? How many of you are those? They grab a toothpaste, you squeeze from the middle, right? Yeah, that irritates me. It needs, I like to do the edge thing and keep it all to the front. Yeah. We could be roommates. You and I could be roommates. That could work. Hypertrophy. So, what do you recall about skeletal muscle and cardiac muscle if you load it? Why do you go to the gym? Right? To get pumped. So if you load cardiac or skeletal muscle, that's striated muscle, it enlarges. Right? That's the whole concept of weightlifting or training. Even if you don't want to get huge, right? You have your specific craft, you get good at it, you develop those muscles, they get stronger, they get bigger. Maybe you don't have to be huge and tear your shirt when you're, flexing or anything like that, but you're trying to get good at your craft. Well, cardiac muscle does the same thing, and as it has a higher load, this enlarges, and that's called hypertrophy or cardiac myopathy. Cardiac hypertrophy, an enlarged heart. Not a good thing, but definitely expected if you're going to increase the load that the heart is working against. Right? In skeletal muscle, it tends to be beneficial. In cardiac muscle, it tends to be problematic. Okay? All right, true story. Not to throw anybody under the bus, but to use true clinical stories. How many of you have heard of Arnold Schwarzenegger, the Governator? Yeah? You know that if you look at old pictures of him, right? One of his sons was like on Dancing with the Stars. Did you guys see that? Some of you are like, you watched that show? I walked by the living room and my kids were watching it with my wife. I don't really watch it often, nor do I admit to it. But anyways, his father, Arnold, was a really big bodybuilder. Okay? Back in the 80s, he was like late 70s up to the mid 80s, he was kind of in his prime from a weightlifting, bodybuilding standpoint. That was an era where a lot of steroids were used. Okay, and then they put in a lot of these rules. It's very dangerous. One of the side effects of taking steroids, anabolic steroids exogenously, even when you're weightlifting, is yes, it builds the skeletal muscle, but it also enlarges the cardiac muscle. So he's had multiple cardiac reduction surgeries. where they literally come in and cut a wedge out of the ventricle and then sew it back together. Chat it. You'll see. It's real. So the heart will enlarge. As it's working hard, it's very common for patients that have an enlarged heart in end-stage chronic heart failure to lose weight like crazy because the heart is like exercising at an extensive rate. So we have this body wasting because they're burning all this extra metabolic energy just trying to run the pump. And so we have this clinical term known as cardiac cachea in these late-stage cardiac myopathy patients. They tend to be very, very thin because their heart is working so hard, even while they're sleeping, just to move blood. All right, left-sided heart failure. Causes. Let me just switch this out real quick. So any kind of damage to the heart, ischemic heart disease, where blood flow to the heart itself is compromised. That would be from like a damaged blood vessel or diseased blood vessel of the heart. Could be like the left anterior descending artery or the circumflex. And it's not perfusing the heart with enough blood. And so you get a region that dies, or you have a myocardial infarction or heart attack. You could have systemic hypertension, which we've been talking about on our drawings. These two are probably the most prevalent issues that will cause left-sided heart failure. A valve disease or any sort of primary myocardial disease, which could be a genetic defect as well. The morphology of left-sided CHF is hypertrophic. It's enlarged. A dilated ventricle. The ventricle kind of blows out. You get pulmonary congestion. We talked about that. It backs up into the lungs. And you get edema throughout the body because you're not bringing back enough of the fluid from the extremity. And the biggest impact on everything is actually on the pulmonary circuitry, the lungs. They have trouble breathing, feel like somebody's sitting on their chest when they're trying to take a deep breath. They have shortness of breath because you're backing up a lot of that fluid that's sitting in the lungs. It's not being ejected out into the aorta. Symptoms, dyspnea, that's shortness of breath, a cough due to the fluid in the lungs. There's kind of this underlying irritation. Orthopnea, so that's shortness of breath, but while you're lying down, even while you're trying to sleep. Again, that feeling of someone sitting on your chest while you're trying to sleep and take a breath. Tachycardia, an increase in heart rate because the heart is trying to compensate. Mitral regurgitation, the mitral valve is between the left atrium and the left ventricle. If you're backing up this direction, you're putting extra pressure on this mitral valve, so you get regurgitation, you get fluid moving in the opposite direction as it goes the opposite way. And you can hear that with a stethoscope. And then you get atrial fibrillation. You get some arrhythmias or some abnormal electrical conduction that's taking place because the heart's trying to get another beat in to eject the blood flow. So I like to talk about it this way because this list of symptoms should actually make sense to you now that you understand like what's happening with heart failure. You follow? Okay, what about right-sided chronic heart failure? Any lefties in the room? Yeah, see, my wife's a lefty. I got one daughter who's a lefty, southpaw. And then the world's always right-handed. Well, we talked about left-sided heart failure first. There is an issue on the right side, but usually the left happens first. And the cause of right-sided heart failure is if it backs up from the lungs, where does it back up to? Eventually it backs up to the right side. You with me? So the biggest cause is left-sided chronic heart failure with pulmonary congestion. That backs it up to the right side. The world always talks about right first and then left. This time we talked about left first and then right. Some other causes would be lung diseases, like lung parenchymal diseases. Parenchyma means functional tissue of that organ. Or a vascular disease in the lung that could cause backup to the right side. So the biggest impact on right-sided heart failure is actually on the systemic circuit because it backs up venous return. And so you could see you're going to get peripheral edema will work from the bottom up. That should make sense. A lot of extra fluid in the periphery. We get pleural effusion, stuff in the pleural space, like around the lungs and around the heart. And then we get congestive hematomegaly. What is that? Hematomegaly. Congestive hematomegaly. What organ are we talking about? What's that? The liver. Hepatocytes, liver cells. Hepatomegaly is an enlarged, congested liver. Because if you back up from the vena cava, you get to the portal system that perfuses the liver. Remember, the liver is perfused on the venous side, right? Whereas the kidneys are perfused on the arterial side. So if you back this up so far down, you get into the liver, now you congest the liver and you get an enlarged liver. All kind of connected. So left-sided heart failure may lead to right-sided heart failure because of or owing to which of the following? Excessive volume retention, poor perfusion of the right coronary, an increased right ventricular afterload, or atrial hypotension. I'm asking, what's causing the right-sided heart failure? What do you think? Excessive volume retention is a result, but it's not the cause. It's the effect, but it's not the cause. Let me ask it a different way. What's a main cause of left-sided heart failure? Was it a preload problem or an afterload problem? Remember hypertension? Afterload problem. So if afterload on the left side caused heart failure on the left, what causes heart failure on the right? Right ventricular afterload, right? So right ventricle, the afterload is coming from the lungs. Instead of the afterload on the left coming from the aorta, the afterload on the right is coming from the lungs. Does that make sense? That's the cause. Remember, right-sided cause, number one cause, is left-sided heart failure. And it backs up to the lungs. Eventually, it backs up from the lungs to the right ventricle. Okay? Arterial sclerosis. You guys ready? Switching gears. Arterial sclerosis. Yeah.
Was right-sided congestive heart failure a sequel to left-sided?
Yeah, so the question is right-sided a sequel to left-sided? Typically, yes, as it progresses. And then you get into global heart failure or total heart failure. So left-sided usually happens first because the patient usually has high blood pressure for a long time. They love salt. They won't stay away from the salt. Okay? Or they have heart attack and they get damage to the heart, and the left side is the one that works the most. So it goes first, and then it backs up to the lungs and puts pressure on the right side, then the right side goes, and then you're on the transplant list. You can usually manage left-sided heart failure for a while, medically, with diuretics and the increasing the urine production. Once you get to the right side, you're kind of, it's lost. Arterial sclerosis. So this is a disease that's not too dissimilar to other types of healing. So you have trauma or damage to the blood vessel, and the blood vessel is going to respond. It's going to heal. So up here, the top image, you see sort of a normal blood vessel. And you can see this demarcation of these sort of dotted blue lines. You've got the external elastic lamina, and you have the internal elastic lamina. And in between there is the tunica media, which is mostly smooth muscle cells, almost exclusively smooth muscle cells. And these smooth muscle cells can contract and they can relax, so you can cause vascular constriction or vascular dilation, vasoconstriction or vasodilation. Well, when the blood vessels are injured, and there's all sorts of things that can cause injury. Hypertension, right? High blood pressure causes injury to the inner lining of the blood vessel. Hypertension for 40 years causes a lot of injury to the inside of the blood vessel. There could be certain agents, chemicals, contaminants. There's a lot of pollutants in tobacco smoke that will make it into the bloodstream that actually cause vascular intimal damage. They damage the endothelium. If the endothelium gets damaged and you lose this interface, you migrate these smooth muscle cells out of the internal elastic lamina and into this intima, and they start to replicate. And as they proliferate out of control. They don't stop because they've migrated to a space that they're not normally. They're usually bound by these two borders. Once they leave this border, there's no more elastic lamina to keep them in check. And so they continue to proliferate or replicate. What happens to the inside lumen of the blood vessel as this gets thicker and thicker and thicker? The lumen narrows. So the smooth muscle cells migrate into the intima. They go through mitosis. They secrete extracellular matrix. They cause the intima to thicken. And these ones here don't contract. Those smooth muscle cells don't contract. They lose their contractile ability because they don't become dormant. They're in a constant mitotic cell division state. So they're not functional smooth muscle cells. And they're creating a narrowing of the lumen of the blood vessel. So arteriosclerosis is defined as smooth muscle cells and collagen fibers migrating into the tunica intima, and the lumen then narrows. This area then becomes hardened because of the extracellular matrix, and it thickens that vessel wall. You get the deposition of extracellular matrix. You get the collection of calcium. You get a region that becomes necrotic because it gets so thick. And so the core becomes necrotic. And so now you recruit what type of cells to get rid of the debris? What type of cells would be recruited in a wound that had necrotic tissue? What's that? Macrophages. That's exactly right. So you recruit macrophages into the wall of your blood vessel to clean up the damage. Okay? Those macrophages engulf debris, some of that debris being lipid or fat. And when they ingest that fat, they become a specialized macrophage known as a foam cell. And those are depicted as these macrophages with the yellow dots in them. They have cholesterol and fat that they've ingested, and they're now referred to as foam cells. So arteriosclerosis is the broader category, like the big term. And then we've got subcategories known as arteriolosclerosis. So note the difference in spelling. There's an extra LO right here versus arterio. So the subcategory, which is arteriolosclerosis, I think of the LO indicating low, meaning small vessels and arteries. That's how I differentiate in my head. And this is very commonly associated with hypertension. You get a lot of small vessels that are diseased with hypertension. Because that hypertension, the small vessels can't handle it as easily. They're more susceptible to high pressure. They go first. And then atherosclerosis this is where you get an atheroma. And this is the most common type of arteriosclerosis, where you have an atheroma. Atheroma literally translates in the Latin to a gruel, like a sludge. And this atheroma is what we're highlighting on this picture. You get a necrotic center. It's surrounded by a fibrous capsule. Sound familiar? This is a wound in the blood vessel wall. You recruit macrophages. There's already smooth muscle cells here. They're not supposed to be. You recruit macrophages. They try to take up as much of the lipid and cholesterol that's been accumulating there. They become what we refer to as foam cells. And in some cases, this gets so thick that you actually create a new vascular supply for the middle part of that tissue. And as this gets bigger, the lumen gets smaller and smaller and smaller. So that's what we're showing here. The pathogenesis of atherosclerosis, AS. It's an ongoing chronic inflammatory response to chronic injury. Think of the chronic injury being hypertension or a chronic smoker. A lot of debris that's in the bloodstream that's not supposed to be there. Could be an unmanaged diabetic patient that has high sugar levels in the blood, because now the blood's more viscous. Remember, it doesn't flow like water, it flows more like honey. So now that creates more of a turbulent flow against the endothelium, causing trauma, and they respond. So you get chronic injury, you get hyperlipidemia with endothelial cell injury, excessive fat causing the injury. These are all the things that could cause injuries to the endothelium. Excessive fat in the blood, because if it has high fat content in the blood, it flows like thicker fluid. Hyperlipidemia blood is thicker blood. Hypertension, high pressure against the luminal wall. Smoking, certain viruses or toxins. I'm not going to cover all of them, but you kind of get the picture. This is something that happens chronically over time. You get the endothelial dysfunction, right? It increases permeability, so you allow for monocytes to migrate out. That's where you recruit your macrophages. They move into the medial tunica, or the tunica intima, but it's now like a modified medial wall. And the activation of these macrophages gobbles up this extra fat and cholesterol, forming those foam cells, and you get what we refer to as lipoprotein accumulation. So these macrophages, you know what they do. They make free radicals. The lipids that are present become oxidized with free radicals present. You get an infiltrate in the intima that's taken up by the macrophages. That makes the foam cells. Platelets will adhere in this area. You could form a clot where you don't want a clot. If this happens on the coronary circulation of the heart, then it restricts blood flow. And that's a myocardial infarction or a narrowing of the vessel, and then all of a sudden you had a clot that formed and you don't have blood flow to the heart muscle itself, and the patient has chest pain. In its extensive format, right, you get this fibrofatty atheroma that's covering it, sticking out into the lumen, preventing blood flow. So the next thing that happens as this progresses from left to right, so this is the progression. This is far worse on the right, and it's early stages on the left. You can see on the right, it's a thicker necrotic area. You get all this extracellular matrix on the right, excessive proliferation of smooth muscle cells. You get necrotic areas. You get continually getting migration of smooth muscle cells, formation of foam cells over here on the right. Early up here, when you get damage, this is where you get the LDL coming out of the bloodstream. This is why we like our LDL levels to be low. Low density lipoprotein is the bad cholesterol. You guys have heard of that? That's the cholesterol that moves from the liver into the bloodstream and floats around in the bloodstream, LDL. HDL is the type of cholesterol that pulls cholesterol out of the bloodstream and moves it into the liver. That's why HDL is considered the good kind of cholesterol, because HDL is low in the blood, high in the liver. LDL is high in the blood, low in the liver. So you get this fibrous plaque. You create C-reactive protein in an unstable tissue. C-reactive protein is typically found in the blood under conditions where you have chronic inflammation, and it helps to activate the complement system. So why would having complement system elevated or the ability to clot blood be bad, or coagulate blood, more accurately said, in these conditions? What are we worried about in that case? If we're in this condition right here, we stimulate C-reactive protein, complement system, and coagulation, forming a clot in the vessel. If that's in the brain, stroke. If that's in the heart, heart attack. You create a tissue here that starts stable and then it moves very quickly to being unstable. If it's an unstable plaque, it's subject to rupture. Then that creates the potential for an aneurysm. And we learned about aneurysms in the neural section, right? Neurovascular aneurysms. But you can get aneurysms other places too. And we'll talk about aortic aneurysms. Maybe we'll get there today. I think we might. Definitely Thursday. So what do these things look like? So on the left side, you can see the picture with the white lumen labeled L. So this blood vessel is a cross section. The lumen, the white, should have been all the way throughout the whole area. But you can see here's this fibrous cap, and you can see the disease. That's a lipid core in C. So that's the atheroma, and you've basically taken the lumen of this vessel, and you've got about a 55 to 60% narrowing. So it's maybe 40 to 45% patent or open is how we refer to that. So you've just cut blood flow by more than half. Does that make sense? So if this is on the heart and the patient's going to go exercise, like climb upstairs to go to the bathroom, and they're going to increase their heart production while they're climbing the stairs, now blood flow needs to increase to the heart muscle, and it's compromised, that's when they have their heart attack. They become symptomatic. You see how that plays out? Panel B in the middle, you can kind of appreciate all the lipid in yellow, all of the fat that's accumulating. Again, this is normal lumen up here, and this should be circumferentially around. This is all part of this atheroma. And then here on the right side, you can see the arrows are indications of new blood vessels, or what we refer to as neovascularization, new vessels. And the arrowheads are calcium deposits. Now, we have very hard water here in Arizona. So what happens if you don't have a water softener in your house to your faucets over time? What do they get on them? Calcium accumulation, that white residue that doesn't wash off, right? You can use white vinegar to get it off. Vinegar will dissolve calcium. A lot of calcium in eggshell, right? So you've done the experiment where you take an egg and you soak it in a glass of white vinegar, and after a couple of days, it's the shell's soft because all the calcium comes out. So these are calcium deposits that are, calcium's a stone, right? It's hard stone. So from a cadaveric specimen here in the lab, this is a radial artery. Here you can see it was a tube, and we longitudinally sliced it. This is from the lab, and then we opened it up, and so you can see this piece and this piece would be brought together and form a tube. We've just kind of opened, and we've just sort of pinned it down. This is normal blood vessel intima. You can see how it's nice and white and glistening. And this is an atheroma. All of this is diseased vessel. You can see evidence of clot. All the yellow you can see is fat, and all of the white kind of bubbly things are all calcium deposits. This is actually hard. To cut into this vessel, we used like a razor blade, and then you pulled, and it crunched like I was cutting stone. And then when you pull it up, it was jagged on the razor blade because you basically were cutting through calcium stone. That's calcium right there. Hard as stone. So we can test this hardness of diseased vessels by doing what we refer to as nano indentation. So you have a machine that pushes down on a surface, and based upon how much it'll deflect, right, it'll give you a force, and it can calculate a hardness. So when we do that, we take these specimens, we get them ready, and then we're going to do like 10 different sites on the vessel. Here's the machine that we use for nanomechanical testing. This is the Berkovich tip, which is basically like a very pointy tip, but it's on a very hard probe. And so these are the different nano hardnesses basically in pascals. So here's a control artery, basically soft, right? No hardness. Here's cortical bone. This is a blood vessel that's diseased. Here's a second one. Now, maybe not quite as hard as bone, but in comparison to control artery that's healthy, right? It's approximating the hardness of bone in a diseased blood vessel. We didn't know how hard it was going to be, so we looked at different types of materials as comparators. And of course, our control healthy vessel was a control group as well. But just to give you an idea of how dangerous calcium can be. So what are the outcomes? What are the outcomes that can occur with an atheroma? Well, in the preclinical phase versus the clinical phase, so this is patients that are in their younger years, you have a normal artery, you might develop a fatty streak, it can move into like a fibroplatty plaque, but it can progress into an advanced vulnerable plaque. And the challenge is, if you enter into middle age, into your elderly years, it's these advanced vulnerable plaques that are at risk of rupturing or becoming stenotic or becoming occluded by a thrombus or a blood clot. So rupture and forming an aneurysm, and then you're going to bleed out. That could happen in the brain, or that could happen at the level of the heart or the aorta, and I'll show you the aorta example here in a second. Or, like appropriately was said earlier, if this narrows so much and you're activating blood in that area, you could clot off that and create a thrombus, which is a restriction based upon clotted blood. Or third, you could actually just enter this to be 97% blocked, and the next time you go to exercise, trying to get up to your bedroom upstairs, as an 85-year-old patient, but 4 out of the 5 major vessels of the heart are 95 to 99% blocked. They're almost like critically stenotic. Stenosis means narrowing where it's almost occluded. So these are kind of the 3 clinical outcomes that you'll think about. So we're going to end on a high note. Okay, how do we treat these? Lots of great treatments. So we can do angioplasty, where you can come in with a catheter, usually through the femoral artery, or from typically the right or the left arm. You can enter up into the neurovascular anatomy or anywhere into the thoracic anatomy. You can put in a deflated balloon. You can inflate the balloon, not with air, but with fluid, because if the balloon ruptures, you don't want to put air in the vessel. If the balloon ruptures and you have saline, it's no big deal. Okay. True story. I was in a few cases with residents that were training on endovascular procedures that inflated the balloon with air. I'm not even kidding. Nothing happened, but like the attending physician said really quickly, "What on God's green earth are you doing?" Okay. Something like that. I can't remember exactly what they said, but it was probably something very flowery like that. Okay. You can do that with a stent which is a metal structure that you push open, you deflate the balloon, the stent stays in place to keep things open. Or you can do what's called a stent graft. You can medically manage with antithrombotics, with like a Plavix or aspirin. A lot of elderly people take a baby aspirin, which is like 85 milligrams of aspirin a day that just keeps the blood from spontaneously coagulating. Not a bad idea. They tend to bruise really easy. So a lot of elderly patients that you see, you'll see they have very thin skin, right? Because as we get older, our skin thins. And then a lot of times they have a lot of like bruises on their arms and legs because they're probably on some sort of anticoagulant. And so they bump into something and all of a sudden it bruises. That's very common in our elderly population. That's usually a sign that they're on some sort of, it's not really appropriate to call them blood thinners. That's really a bad word for it. But they're on an anticoagulant. So be educated. Don't call them a thinner. But it's thrown around the hospital system all the time. Blood thinners, blood thinners. They're really anticoagulants. Make sense on how we can treat? Lots of great options. But early detection is the most important. And good diets, regular exercise, genetics plays a huge component into this. So you kind of don't really get to choose your jeans, right? You like the joke said, you always wear the same old jeans, full circle. So you can't really pick that. So you can manage sort of your environment as best as possible and learn to see when you have issues, and then get treatment or intervene. So let me show you this. I thought I had. Oh, here it is. So this is a system that I worked on. Oh, you can't see that. This is a system that I worked on at Gore. This was what basically brought me to Flagstaff before I came here to the university. And so this was called the thoracic endograft. So this is for treating a damaged aorta and a potential for aneurysm. And this type of technology exists for like so many places in the body now. So we were the first to launch this in the United States, and we launched it all over the world. I traveled like 2 weeks out of the month. I was gone doing cases, and it was a lot of fun. But we had little kids, and it was good for a season, and then it was time to not travel for work. But this aneurysm, which is a vulnerable lesion, this is at risk of rupturing. And the aorta, your cardiac output is about 4 to 5 liters per minute. Average 70-pound kilogram individual has about 5 to 6 liters of blood. So you rupture that, you'll exsanguinate internally your entire blood volume in about 1 minute and 20 seconds. Not much time. Well, if that happens and it's a full tear, you're gone, most likely. If it's a partial tear and they can calm you down and lower your blood pressure, they can get you into the cath lab and they can put this device in, they can save your life. Okay? So we worked on this, and then we worked on making it more conformable. And so this was sort of my product when I was there at Gore, and it's a great product. So you can see the guide wire coming through, and this is the aortic valve right here. So on the other side of this aortic valve is the left ventricle, going back to our box diagram. So this is a floppy tip, so it's very atraumatic. So it hits the aortic valve, and it just kind of like a spaghetti noodle. It just kind of like flops and doesn't do anything. Every now and then on every heart cycle, this might actually enter into the left ventricle, and then it gets spit back out. Okay, you don't really want it in here because then the heart starts acting weird. So you try to keep it up here. But you get the guide wire in, and then it's like a monorail system. You put this device over the guide wire, and I'll walk you through this treatment. And you can do this for damaged large vessels in pretty much any part of the body. So here comes the device over the guide wire like a monorail. You're going to back it up here so you're not blocking the vessels that go to the head. You pull a ripcord, which is like almost like a dog food bag piece of string, and then this device deploys in place, and then you can position it slightly and then finish the deployment to seat it and exclude the aneurysm. So the blood flows through the device and no longer perfuses the aneurysm. It's pretty clever. A lot of fun to work on. These devices, this is a hometown hero made by W.L. Gore and Associates, and it works really well. Has saved hundreds of thousands of lives. Okay, so a lot of great stuff that we can do to treat these things, and now hopefully you have a good sense of what the diseases are, how we can treat them, and we'll pick it up here on Thursday as we finish out. We'll start with ischemic heart disease, and then we'll have our last lecture of the semester. Okay? It's going to be pretty chilly in the next couple of days, so dress warm. I'll see you all on Thursday.